Welcome to Think Like a Nurse, the video outreach of Keith RN. Today's topic, NANDA versus clinical reasoning. Who doesn't like a good fight, especially when it is a likable underdog against an established heavyweight champion? That is what made the Rocky movies mythic in its message and popularity. We all like to root for the underdog. Today, in nursing education, we have a similar battle with an undisputed heavyweight champion, but an up-and-coming contender. In this corner, we have the undisputed heavyweight champion of the nursing education world for the past 30 years, with 205 nursing diagnostic statements wrapped into 13 separate domains and 47 classes, NANDA Creed. But in this corner, we have a scrappy newcomer and contender with only 9 questions that reflect how a nurse thinks in practice, emphasized in the past by Linda Caputi, and the main message from Patricia Benner's educating nurses, Rocky Reasoning. Though the first Rocky movie, he lost by a split decision, we know from Rocky 2 that he didn't go away, but came back in the rematch. And after a hard-fought, bloody battle, Rocky the underdog prevailed. In the same way, NANDA is not going to go to the mat without a fight. And it will be a hard-fought battle, as colleagues within even your same department will be split as to whether we should stay with what we know and are comfortable with in NANDA language, or whether we should let this relative newcomer of clinical reasoning have a shot at even getting into the ring. Today, we will examine in further depth clinical reasoning, and afterwards I will let you decide who deserves to win the battle in the title of taxonomy that reflects nurse thinking. For this blow-by-blow comparison of NANDA versus clinical reasoning, we will situate a patient scenario of sepsis and then compare which emphasis will best prepare our students to think like a nurse in clinical practice. Here's the scenario. Mr. Myers is a 64-year-old man who has noted progressive redness and swelling of his left lower leg over the past week. The redness started in his lower leg and has now progressed up to his knee. He's been feeling more weak and not feeling well in the last 24 hours. He became concerned and came to the ER when he began to have a fever at home that started 8 hours ago, as well as increasing pain in the left leg. You collect his vital signs: temperature 102.9, pulse of 118, resps of 20, blood pressure 128/68, and SATs of 95%. Pain is 6/10 in his lower left leg. Your initial assessment: he looks comfortable, appears tired, and easily fatigued. His skin is cherry red from just below his knee all the way down to his foot, and has unilateral swelling on that same leg of 1+ pitting edema. Neurologic, he's alert and oriented. Respiratory, no concerns. He's within normal limits. Pulses are 3+ with the edema in that left leg. Heart rate is regular, S1, S2, and his abdomen, GIGU, within normal limits. Doctor orders a CBC and a BMP. His hemoglobin is 12.9. White count is 18.8, and his neutrophils are 96%. Sodium is 138, potassium is 3.9, glucose is 348, and creatinine is 1.2. So now, let's start with the undisputed heavyweight champion of the nursing world, NANDA Creed. And let's see what a NANDA-driven care plan would look like to see how a nursing student would prepare to care for this patient and possibly rescue if needed. The student begins to recognize the presence of an infection based on what her content was in her nursing lecture and the textbook, and begins to cluster data that supports infection. Patient's weak, has the redness and swelling in the leg, fever, pulse is high, has pain, and the white count is elevated. Now, we need to quickly pick a NANDA nursing diagnostic statement that will lay the foundation of needed nursing interventions and rescue this patient. But OMG, there's 1,000 pages in my nurse's parking guide of nursing diagnostic statements and 205 statements on my nursing card. How am I going to have the time to quickly identify the needed priority? But I will do it, And I look and I find, you know what? There is one that fits. There is a NANDA statement about infection, but no, it's a risk for infection. And this patient has an infection. I can't even use it. Let me look and look through my card. You know what I see? I see something that might fit. Under the activity rest domain, fatigue. My patient complained of fatigue and weakness. There you go. I can now establish a NANDA-based priority and establish my plan of care. But is this the problem? And is this going to help our student rescue this patient and think like a nurse? She could even use acute pain, but is that the primary problem or is it secondary? So though I have established that I have two statements of NANDA that will fit, fatigue and acute pain, I'm going to choose the old reliable pain diagnostic statement of acute pain related to the infection, but I can't state the medical problem, so I will instead state related to the inflammatory response with physiologic consequences of increased capillary permeability, as evidenced by the patient reported pain of 6/10. So I will develop a plan of care in all of my nursing interventions based on pain, such as the physician-ordered pain meds, assessment every 2 to 4 hours, distraction, etc. But for those of us who know better, is this the current problem, and will the emphasis of pain prevent this student from recognizing the bigger picture, which is sepsis and the potential for septic shock? Let's look at the other challenger, Rocky Reasoning, and let's give him a shot and see if clinical reasoning and the 10 clinical reasoning questions can do any better to rescue this patient and think like a nurse. This same student begins to recognize the presence of infection of some kind and begins to cluster the data that supports infection, but now uses the following template of 10 clinical reasoning questions. Number 1, what vital signs and assessment data is relevant that must be recognized as clinically significant to the nurse? Recognizes the same data of weakness, redness, swelling in the leg with pain, the temperature is up, the pulse is up, and the pain is present. The nurse then asks question number 2 of clinical reasoning. What lab and diagnostic results are relevant that must be recognized as clinically significant to the nurse? Well, the white count is 18,000, the neutrophils are 96%, and the glucose is elevated dramatically. That has some significance in this scenario. Number 3 of the clinical reasoning question, taking this data, what's our medical problem that your patient is most likely presenting with? Now, because this student was taught by a nurse educator who emphasized concepts in her classroom and not content, SIRS, or Systemic Inflammatory Response Syndrome, was discussed, and the recognition by the nurse that 3 pieces of data in this patient scenario reflect SIRS that reflect not only just a local infection of redness, but this is likely going to go systemically septic. The temperature is up, the pulse is up, the white count is up. That's our 3 pieces of data that are very significant. Number 4 then, what is the underlying cause or pathophysiology? The nurse then needs to understand the significance of SIRS and sepsis, which they do. Number 5, now what body system will you focus and most thoroughly assess based on the patient's chief complaint and primary concern? Obviously, we're going to be focusing on the cardiac, of blood pressure, heart rate, and skin color, as well as the respiratory for the potential for increased oxygen needs and tachypnea that is not currently present but could develop, as well as the skin of the lower extremity and that progression of redness, reflecting a progression of sepsis. Number 6, based on the data you've collected, what is now your nursing priority? Not NANDA, though it could be. My nursing priority here would be, I need to establish an IV access and start 2 things, IV fluid resuscitation and IV antibiotics once our blood cultures are drawn. And then obtain all needed blood work as soon as possible so we can get this moving and stop sepsis in its tracks. Number 7, what interventions will you initiate based on this primary or priority concern? We have just done that when I discussed number 6. Number 8, we need to be looking for the worst possible complication in this scenario. And what is it? This patient could go septic and going into septic shock. Therefore, number 9. What are you going to be looking for? What assessments to identify and respond if this worst case scenario presents itself? Well, we need to monitor the vital signs, especially blood pressure and heart rate, as well as temperature, and looking for any confusion or other systemic changes in their status. And number 10, what's the relationship, or why did the doctor order the following meds and medications and treatments based on the patient's primary problem? Well, the doctor ordered blood cultures, he ordered a UAUC, wanted us to outline the skin, wanted us to establish an IV, give saline, and he also ordered an IV antibiotic. I want to know the rationale for why is the doctor doing what he is doing, and then combine that with your nurse thinking and rescue this patient. In closing, to determine who should prevail in this battle of NANDA versus clinical reasoning, the scorecard is really quite simple. Ask yourself which approach and taxonomy reflects how you actually thought when you were in clinical practice as a professional nurse. If you are honest, this battle really isn't even close, and clinical reasoning is the clear winner. Yet in nursing education, NANDA continues and still prevails. But the tide is turning, and as educators, let's be on top of this wave and be a part of the needed transformation to emphasize and transition to clinical reasoning that reflects nurse thinking. But clinical reasoning is much more than a pedagogy or a way to teach our students. But the lack of this approach to nurse thinking and failure to provide opportunities for our students to practice this thinking will impact patient outcomes at the bedside that could ultimately influence whether a patient lives or dies. Therefore, my challenge to all of you as educators is simply this. Talk to your students about the strengths and weaknesses of NANDA and dialogue about this and see if they agree or disagree. If you want to take the plunge and promote using clinical reasoning as a template to promote and practice nurse thinking, use the link to this website and take the same questions that I have used in this short video. I have as a link that you can use in clinical practice. I will post it as a Word document and allow you to modify or change it as needed, because for Keith RN, the way that I roll is that my copyright is your right to copy, as long as you use this information to promote the learning of our students in the classroom or in the clinical setting. Together, we can realize Benner's transforming vision of nursing education to not only promote the learning of our students, but more importantly, better outcomes for the patients they care for. Thank you.